started. So the format is something like each of us will say something until we see the signs of boredom starting to appear in the audience. Each of them will have about 10 minutes or so of material. And then you're supposed to be, the screen covers it now, you're supposed to be dreaming about questions while this is going on. Anything you want to ask. This panel is not afraid to say we don't know. I learned that a long time ago. Or I don't recall. That's the other famous one. You can say, I used to know, I just don't recall. So we'll go through our little spiels. And then any questions you want to ask, we'll try to field that amongst the panelists and see what's going on. And then if we get stalled out at about 5 till or 12 o'clock, we may even ask one of you to come up and give a talk or something. I don't know what we'll do then. But again, this one is about what I thought was kind of a, I don't know, superfluous question or something or so. Do we still need consent and research? I'll go last and I'll explain my particular opinion, but Kelly and Phil, I'll let them go first. Flip a coin, alphabetical, last
Ladies
name,
first.
first name.
So kind
Sorry,
of.
not
at all.
I'm an Englishman, so I'm not.
It's very polite.
Be
Go
polite.
ahead and tell them who you are and why you're here and how you know everything about it.
Okay. So I'm Kelly Kane. I'm an assistant professor of human-centered computing at Clemson University. Go Tigers. I did my PhD in engineering psychology at Georgia Tech. I was a principal research scientist in a Center for Health, Law, Ethics, and Applied Research at Indiana for a few years. And betraying Clemson, I did my undergrad at South Carolina. So I'm consistently in trouble with everybody around the Southeast for cheering for those variety of teams. I want to tell you a little bit about engineering psychology, since I feel like, or human factors, HCI, these are all words for the same thing. I feel like at this conference mostly have lawyers and practitioners. I feel like maybe I'm the only person here who medical practitioners? No?
Yeah,
that's what I meant. Yeah, no, which is great. I love talking to everyone like that. But often I sit in a school of human-centered computing, so I talk to a lot of technologists and a lot of social scientists. My research really sits at the intersection of those two things. By training, I'm a behavioral scientist. The science that I practice is the science of human behavior. So I try to understand human behavior, and it's how we can design technologies so that they're easier for people to use, more helpful, and also to understand the world that emerges from a technologically mediated environment. So that's a little bit about my background. Now about what I'm going to talk about today. I'm actually not going to talk precisely about consent. So even though it's very polite for them to have me go first, it may throw you off just a tiny little bit. What I'm going to talk about is our privacy-enhancing behaviors and some work that I've done on designing a privacy-enhanced electronic medical record that allows patients to express where they would like specific items in their electronic record shared. So you might think of that, maybe that's a precursor to consent. Maybe it's a form of consent if patients are actually making those decisions within a technology system. Maybe that means if I'm making this choice that I want this specific piece of health information to go to this specific provider, you could think of that potentially as a form of consent. In the project, I didn't characterize it as consent, and my research team didn't characterize it as consent, but I think it's certainly relevant to this panel. One thing I'm going to try to avoid is talking about too many numbers. I know Barb Evans said that numbers make lawyers very anxious, and I definitely don't want to do that. I will show you one graph because I can't avoid it. I am a scientist, but other than that, I'm going to try to talk more generally about this project. For me, where this project came from was the understanding that people engage in privacy-enhancing behaviors in all areas of their life and in a very dangerous place of their life, which is when they're talking to their medical providers. The reason that they often don't reveal information to their providers is concern for privacy. They're afraid of information that they reveal during a clinical encounter being shared outside of that clinical encounter, outside of the patient-physician relationship that they trust. And people do. They really trust their medical providers. They don't trust that information in that particular event will not get outside of that relationship, and that's a big concern that they have. There are a variety of numbers associated with this. The number that I have is 1 in 8 people reported in 2006 that they had engaged in this sort of behavior recently. Just in the plenary panel before, we heard 9 out of 10 doctors reported that patients had engaged in this kind of behavior. Clearly, that's a big issue. So the background for the project that I'm working on was to create a system that allowed patients to have a greater degree of choice to determine at a very granular level what personal health information was shared with whom and for what purpose. And we did that both on a technological level and also on a human-centered level, and I led the human-centered and human factors portion of that work. We based our work around the fair information practice principles, as well as bioethical principles. We had bioethicists, physicians, and also medical providers on the team. And our goal was to develop a usable browser-based user interface for patient control over their data. How I achieved that from this human-centered perspective was by getting out there and talking to patients. So I interviewed 30 patients, 70% of whom had highly sensitive information in their health records, in an electronic health record system that exists in Indiana. My collaborators are at Indiana School of Medicine and Regenstrief Institute. So 70% of the people we talked to had highly sensitive information in their EHR system, in the Regenstrief EHR system, or the Indiana State Health Information Exchange system. That's how we categorize highly sensitive information rather than just health data, which I consider sensitive anyway, is by the NCVHS categories of what is sensitive health information. And this is things like HIV, domestic violence information, and so on. There are actually 5 categories: mental health information, reproductive and sexual health information, as well as substance abuse. All are those categories. We also really want to make sure that we got a broad sample of participants. So we had almost 40% of people had less than a high school education. We had more than 20% of our population were African American. 20% of our population had less than $5,000 a year in income that they reported to us. Variety of health status. So we really got a huge variety in terms of opinions. And here's where we get to the part that I actually want to show you with a graph. What we did was use a card sort methodology, which is a human-centered computing and HCI, human factors method, to elicit from patients who they wanted to share specific items with. So we had cards that had different items of health information, and we had other cards that were potential recipients of the information. What you'll see here along the x-axis are the different potential recipients of health information, starting with primary care physician, a mental health practitioner, a specialist, emergency room physician, nurses, all the way to the end where we have a non-treating physician, government, and researchers. And what you can see on the y-axis, the percent of information of percent of items, cards. Items would be something like demographic information, cancer screening, cholesterol tests, these kind of medical items. Percent of those items that people wanted to share across these potential recipients. The bars, the darker gray bar, the black bar and the gray bar are different by the less sensitive information and the highly sensitive information. The highly sensitive information is those categories that I mentioned before, the NCVHS categories of highly sensitive information. A few things that you can see from this graph are that overall, people generally preferred to share more of the less sensitive information, right, across the board, and that was statistically significant. The other thing that you can see here is that there's a huge difference between the amount of information that people want to share with their primary care physician and with, for example, a non-treating physician. This difference is also statistically significant. And that's important. People are willing to share more information with a provider they have a relationship with someone that they trust, than they are share with people who they don't necessarily have a relationship with and also don't believe are actively involved in their care. For this particular panel, what I want to point out here is that researchers are down here with administration, family, government, and non-treating physicians. the question of our panel is, do we need consent for research? This evidence, to me, although I haven't analyzed it with respect exactly to that question, indicates that people overall don't expect their health information to be shared with researchers without their consent. They think, I'm happy to share my health information, sensitive and less sensitive, with someone who's treating me and actively involved in my care, but I would like to be asked if researchers are going to use my information. And this is explicitly what I heard. I did a quantitative survey and also a interview with folks. And during the qualitative analysis, this is exactly what they said. They said, I would like to share. I would like to help other people. I would like to provide researchers information that might help prevent other people from going through what I'm going through in the future, but I want to be asked. And again, to me, that indicates that we do need to continue this, the practice of consent in research. People don't believe currently that it's happening, that their health information is being used for research without them being asked. So I promise that's the only math I'll give you. I will read to you just a few quotes about why patients said that they had preferences that were like this. Participant 18 said, is there really anything a lab technician has to know when discussing a particular lab test? Let's say you have something that they needed to know. They might have limited access to information about me, but they wouldn't see everything. They wouldn't see an entire medical record. So in this comment, the participant is in a very nice way explaining to us that they think different recipients should have different levels of information. And for example, a very specific lab test, that whoever's performing that test may need information, and they're willing to share that very specific information, but they wouldn't need everything in the entire record. Another patient who had a lot of information in her health record, she had a lot of health issues over the course of her life. She said, the primary doctor, that's fine, they can see everything. Somebody important, like the doctor, should also be in control of letting other recipients have it. Yes, go ahead and let that person check it out. There's just so much stuff in mine. I wouldn't want everybody to see all that. They also had ideas about need-to-know basis for treatment. They thought different providers should receive need-to-know access to their health records, and I will just tell you that that's exactly opposite of the way the Indiana State Health Information Exchange is currently designed. Currently, the way the system works, from a back-end perspective, is that the database of all of the records is open to all of the providers in Indiana. So if you're a provider, and one of my research assistants happens to be a provider, if you're a provider, you can go in and access anyone's record, whether or not they're under your care. You're not allowed to. It's not legal. And there are checks in place. If you do that, someone will follow up with you, sort of this audit idea. But currently the system is designed that anyone has that access. That's not the way patients thought it was, and it's not the way patients wanted it to be. The way patients thought it should be is I have control over granting access to different items, or potentially a trusted provider should have that. So a primary care physician may be able to say, the nurses in my practice need access to this, or this lab technician needs access to this potential bit of information. But currently, it's an all or none system. So if you have data in your electronic medical record, all of that goes, right? It's not segmented in a way that's granular, that you could say this bit of information goes and this bit of information stays. What we're working on now, along with a team of designers, is designing an interface for patients to be able to actually express those preferences. And actually, I could show you this one too really quickly. And we're testing this with patients. We're using an iterative development strategy with a team of designers, and we're doing usability tests to make sure that it's easy to use and useful. What you see here is kind of an introductory dashboard. It tells you currently what your settings are, how many different people have access to your health records given the settings, and then it also provides you with this updated information about when your data were accessed and by whom. And that's one of the critical elements we think of a privacy-enhanced electronic health record is, number one, for fair information practices from a privacy perspective, from a psychological privacy perspective, The first step is giving people access to what's in their medical records, and none of our participants knew what was in their medical records. That's the first step. The second step is letting them see who's accessing the medical records, and this is a step toward that direction. What you'll see over here, this is what we called secured data, but we've changed the name of that at this point, is a place where this notes recipients that you don't have any control over. So there are recipients of your health data that you don't get to say whether it goes there or not. On the other hand, in other setting screens, there are recipients that you may be able to actually control. So giving them the control, giving them that interface to actually make those decisions is the next step that we're taking. And this is being pilot tested in Indiana at the end of the summer and in the fall. So Indiana has now, at least in a small portion of its system, set up a pilot so that the data are segmented and patients can make decisions not at the as granular a level as I would like for it to be, but at a categorical level, whether or not to share information in their health records. So we're piloting that with both getting feedback from patients and also providers. The providers are not happy about it. They feel like it's going to be a huge problem. They hate the idea that they won't have access to everything in the record. But we're going to get their opinions and get their feedback and see what's at the heart of that dislike. From some sort of totally anecdotal data that we have at this point, it sounds like a lot of it has to do with repeat folks who come in trying to get pain meds, and the doctors don't want people to be able to hide that information in their records. But if that's at the heart of it, that shouldn't apply to everybody else. And maybe certainly there are things technologically that we can do to fix that. So that's what we're doing in terms of consent. That's what I think that the research that I'm involved in that has to do with consent. And I look forward to your questions and also the rest of the panel.
This is very interesting because, leave that up just a second,
sure.
because it does broach very much over into consent for research. Mm-hmm. I would say the world we live in right now is somewhere in here where, generally speaking, if you sign some general front-end consent form, and then someone writes not a real sophisticated treatment type research protocol, but maybe a retrospective chart analysis type protocol. I want to look at all people who had this over the last 30 years. They don't necessarily have to come to you to go back and do that. It depends. It's very state specific, very institution specific, but that's what I was saying. Think about now, so just think about if you saw a report, I can imagine this number would be more than 25, but it might be, a big number. How would you feel to learn that many people had access to your record, whether it was for research purposes or not, without you even knowing about it? That's kind of a theme for what we're going to talk about today. Thank you. Does anybody have any specific questions for Kelly?
So I have a couple of comments. One question and I guess a comment or two. Some years ago, the director of the Indianapolis the Regent Street Health Information Exchange made this comment publicly.
Mark or Bill?
Mark.
Okay. Who's no longer the director.
I understand that. He said, if you want to get care in Indianapolis, you have to consent to be part of this system.
Whoa.
That was a public statement, so I'm not, it's on the record. So I'm assuming that since you're working with them and they're implementing this system, that their attitude
piloting.
Well, even piloting, even letting you near the system, letting you talk to them, I assume that their attitudes about this have changed, at least somewhat.
Well, there has been a change. So Bill Tierney is now the director at Regent Street, so he has a different perspective than Mark, for sure. I think that they're scientists. They're open to the idea that it might be a better system to empower patients. Certainly it seems like a decent hypothesis to me. We are testing this. Like I said, there has been pushback from the clinicians at Regent Street. Maybe that's partly cultural from Mark being there. But the clinicians that we've talked to about it, anonymously say, I I don't want the liability of a patient being able to, a patient tell me that I can't see information in their records. When I make the point to them that they currently can't see everything about a patient's history, they don't seem to really get that. We don't have complete medical histories for everybody that's in Indiana or anywhere else. So physicians are always, providers are always practicing with a limited set of information. That doesn't seem to convince them either. They think it's a terrible idea to not have all of the information. My point is it's better to have a relationship where your patient will tell you all of the information than it is to have a system where the patient feels like they are absolutely disempowered to have any decision making about what they reveal to a specific provider or not.
So that was the comment I wanted to make, is that I don't think it's specific to Indianapolis. You know, in talking to providers about this all across the country, the providers would like, I mean, when you first talk to them, what they want is they want an electronic system that automatically gives them all the records without the patient's consent. And so I say the same things to them. First of all, you've never had all the information, and you cannot have it, and you quoted some of the surveys. You know, the surveys show that patients are already unnecessarily, in my opinion, engaging in information-hiding behavior because they don't realize how crazy the system is. They don't really have to worry about hiding information because it's mostly not there anyway. But they already do this. And so the point I make to them, to the docs, is that if, you know, say about 15% of patients are already engaging in this behavior, that's what I've seen in surveys. If you try to get the information without consent, those people are going to organize politically and shut you down. And I think that things like the lawsuit in Rhode Island by the ACLU against the Health Information Exchange, even after they've engaged extensively with the community talking about consent, is, you know, evidence that that's going to happen.
Well, you said, you know, the point that you made at the very beginning, saying that consent to complete sharing of all information across boundaries as a prerequisite to receiving care, that is not in my understanding of consent.
It's not consent, it's coercion.
Right.
It's coercion.
Yeah.
You know, that's coerced consent. But I want to make one other comment, and because you made this example, and I think it's a good example, which is the issue of pain medication, or I would frame it more broadly as Schedule 2 prescriptions. So there is, in my view, just like there are limits to free speech, there are limits to, you know, all sorts of things. There, even in the European Union, where there's a constitutional right to your information, there still are certain situations where there's an overriding public interest. Schedule 2 medications is one of those. And so if you talk to Deb Peel, unless she's changed her mind, what she'll say is patients should have the right to withhold that information. I disagree with that. I think a good compromise is that if a patient has Schedule 2 prescriptions that they want to withhold, they should be able to withhold them, but with the understanding that every provider that accesses their record is going to get a message saying this patient has one or more Schedule 2 prescriptions that you are not seeing. Because otherwise, you've created a system that facilitates crime. And no one wants it.
Well, so I think, you know, the great thing about having this evidence base, and that's coming at this from a scientific perspective, is if that's the big problem, if that's the big pushback, I've heard that as being an issue. The other one is liability that often comes up. But so we know if we figure those out, if we really understand what those barriers are, we can come up with technological solutions to those. We can come up with ways to address that, and it doesn't mean that it has to completely block the idea that patients can't, you know, patients that don't have those issues still should maintain privacy over their health information.
My legal colleagues consistently tell me that your liability for patient withheld information in an electronic system where the withholding is documented clearly is actually less than in the current system where...
Maybe you asked, maybe you didn't.
Right, where the presumption always is you should have asked, and you should have found out what the information was. And it's very difficult to mount a defense saying, well, the patient withheld that information from me. There's not much sympathy. So, but it wouldn't hurt, in my opinion, if we had clearer legal legal judgments in that respect, so that you could really assure physicians that in this kind of a system, if the patients decide to withhold the information, you are completely not liable.
And I have to tell you that from, again, talking with the patients, we have so much wonderful qualitative data. Patients don't want to withhold it from people who are trying to help them.
Of course.
You know, and I was actually really surprised where emergency room physicians ended up on this chart, right? Emergency room physicians are, they're down below sort of mental health and specialists, but they want emergency room physicians to have the information that's relevant to treating them, and they want any provider who is treating them to have the most up-to-date information about them. You know, but they have really good reasons and really good examples of why they don't want something that happened 7 years ago to be seen by that emergency room physicians, or they don't want this one doctor in this small town that they go to know about a specific element of their record. And so I think like Deb said, we have to trust people to make good decisions here. And I think what we would see is if we gave them that control, they would be much more willing to share information with providers, not with the entire health data map that we saw LaTanya present, but they would be very willing to share with individual providers.
But don't you agree we also have to educate them to be able to make those choices, to really understand the implications of the choices they're making?
My perspective is that we can design systems that are easy for people to use, and I agree maybe education has some part of it, but we can probably take that discussion offline.
Phil's going to tell us how to do that. Yeah, go ahead.
I used your chart a couple months ago, Bill Pugh at Marshall University School of Medicine.
Great, thanks.
That number on research and government is the answer really to the de-identified and non-consent, and the IRBs doing their own determination. You mentioned earlier, spot by spot is completely inconsistent. We're getting the same pitch everybody in the country is. They're going to every university, IBM's offering free software, we're going to do big data, we're going to do all these things. My comment to our president was, when we get this great result, take a look at that number over there, and then tell me what you're going to tell the community when we announce our findings. And they find out that you not only use that, but you use Kroger data and everything else out there.
Yeah.
The only thing I would ask, if I'm very familiar with the paper, is it be expanded in terms of the ends kind of modest.
Yeah.
And if we got into the hundreds instead of 30, 40, it would be a whole lot more powerful in making the case. What the other gentleman said earlier is, it really scares me, because I think we all know pragmatically that what's happening is people are being extorted into giving consent. If you can't find a physician to treat you unless you agree to this, and at the same time we've got this contradiction on research and government, and in terms of the research side, long ago, like the Helsinki Declaration, recognized that there's risk due to data-only research. So, but lovely stuff.
Let's move on. So,
okay, can I have one caveat? We did not, with this was part of the large card sort, so I did not specifically ask individual participants about, also there's problems mathematically with anonymity, or guaranteeing anonymity, but I did not specifically ask them for research if their data were anonymous, would they be willing to share it with researchers? So I didn't ask them explicitly that, and I think that the numbers that you see here, if I asked that explicit question, I think that they would be much higher, and people, if I guaranteed them anonymity.
Means, and then we get
and then it's not, yeah. So,
okay, well.
Thank you.
I think there's a Livestrong, I think it was Livestrong at Adam Clark, wherever he was, when he did publish a study showing a very high percentage of willing to share, I think it's anonymous, but based on what we've been talking about the past 2 days here, what does anonymous mean?
Right.
Yeah, it's interesting. Why do you think the Susan Komen Foundation and Livestrong and people like that get that high degree of participation, and that what would almost seem contradictory a little bit to the data that was presented? I have a theory it's more of that beneficence, I'm doing good for other people. It's to the extent you can identify with your own personal needs, but also how they might help society at large. And there's a certain classes of people who feel, or in such desperate situations, that they will probably just say, use whatever you need if it helps another person.
I think that's what you see on patients like me. where people are very sick and they just want to, they're not worried about their data, they're worried about dying.
Yeah.
And, but I think it's also, I mean, this is a complicated issue. This is not a simple, yes, I want all my information available for this, this, and this, and not for this. It's nuanced, but I think it's worth remembering the IOM study that was done, that actually Alan Weston did the survey, asking people in a large sample across the country, would you be willing to share your information for medical research without your consent? 1% of people said yes. And then the next question was, well, would you be willing to share your medical information for research with consent? Over 80% said, oh yeah, I'm happy to share it with consent. I think for research, people just want to know, and my view is, and I look forward to more data, that people want to consent by study. They don't want to do the Mayo type consent where, when you sign in, you say, I can use my data for any medical
here's my car,
research
my
you think
children.
of
Yeah,
any
that's
time
it.
in the future, and no problem. They want to be able to hear about the studies because I think people want to know about it, and they get a good feeling that that's an interesting study. Yeah, I'd like to contribute my data to that. And that makes me feel good that I'm doing that and contributing to society.
So
But
Phil,
there's an interesting, just to pick, I'll
Yeah,
I won't
go
even-
ahead-
I'll
go ahead
introduce
and
myself
start.
after I pick up on this point.
pick up on that and then start.
So this is one of the questions I want to tackle when we talk about research. What's been interesting to me over the last couple of days, because I'm coming here from the UK, this is a radically different concept where you've already got basically what we would term market research, commercial stuff going on. We consider research, in the health context to be something that goes on inside the hospitals, the university hospitals. It's always an academic thing. It may be starting to become commercialised a bit more outside of the NHS, and certainly with the big data companies coming in. But exactly this point is consistent across countries and consistent across studies. People, basically when asked, if you are going to be asked, most people are generally happy to provide their medical data for the purpose of research. The thing that's the subtlety, if you like, in this sort of area that we're in now is that in order to find or match the request for certain studies, you are going to have to profile people within the population data and, crucially, actually identify them to go and ask them if they want to be involved in the study. So this starts to, for me, it starts to say, okay, there is a two-stage process here. One that you can declare your general availability for being asked if you would like to participate in research, which can be a one-off consent mechanism, and understand that means you are going to, your data is going to become part of a general property which can be analysed and within which you specifically can be picked out for certain characteristics in your medical record, and then the proper process, the due process of asking consent, which I think, Declaration of Helsinki makes the question of this session really redundant. I don't think anyone in medicine thinks there's any real reason why why we should move away from having consent for research.
There are here.
There are.
RFPA withdrew.
I mean, institutional review boards routinely approve research without consent.
Without consent.
Where they say there's no possibility of harm, and it's too administratively difficult to get consent.
Right, and we have a similar process
It's
in.
routinely done.
Yeah.
Now, I haven't been involved in a lot of IRB stuff for a number of years, but it seems to me that this argument of being administratively difficult needs to disappear. Because it's no longer, with electronic communications, it's no longer administratively difficult. But I think we do need to set up a mechanism where people can say, yes, I'm interested in being asked, but, and I understand my data is going to be searched and looked at so as to know whether to ask me, but I want to know that all that searching and so on is not revealing my data to
anyone else. Yeah.
And that if a researcher comes and says, I want patients with this, this, and this, and this, that the messages, the identified messages that might include me, are unknown to the researcher.
But this is good study protocol. Sorry, I misspoke when I said, like, yeah, obviously research. There are even in the UK there are mechanisms, because we have a essentially sort of nationalised health service, a monopolistic government provided health service. It is done with the law. Yeah, there are simply statutory overrides. There's something called it's Section 251 of the NHS Act 2006 or what have you. But essentially the Secretary of State says, because, and again, it's because it's inconvenient to gain consent from every sort of potential participant, we just are going to allow this particular research study to do it without consent. Unfortunately, because that mechanism is there, that mechanism is now being used as the NHS is moving towards more availability of data and actually sucking up data from where traditionally it's held, which is with the general practitioner on GP systems. Yeah? And this is now being used not for, sorry to deviate from the research question, but not for research purposes, which people would, if asked, be happy about, but for administrative purposes, other ones down this end of the scale. So what it seems to me is that consent is sort of, the obvious implied consent when you go and seek actual healthcare from a healthcare practitioner. I don't think anyone's in any disagreement about it. As we move down this graph, we're finding more and more justifications, whether it be from governments or a different situation in the US, saying, well, it's just a little bit inconvenient. We don't think maybe that we're going to get all the data that we want if we ask people, and so we won't. And as you said precisely, this is what I am. I am a privacy advocate. I am a campaigner. I campaign on behalf of a whole bunch of people. We've fought various privacy battles over in the UK over the years. We stopped, we reversed, we got rid of identity cards in the UK. That was the sort of lead issue for the campaign which I set up. But we had to start campaigning on all sorts of fronts around DNA. It was the criminal forensic, inappropriate criminal forensic use of DNA, storing innocent people's DNA profiles on a police database. Not just a few, we're talking about millions of people. And in health, it was the extraction of information from people's GP-held records without, explaining to them or giving them a choice that drove us to start to say, well, hang on, there's common themes here, and what are the mechanisms? Which is why I'm really interested to see your work here, Kelly, because what are the mechanisms? The challenges that we face are actually quite simple, given that it's data, given that it's something now that is, either sitting on a system or a screen that's at your GP, or something you potentially even could access yourself, although there's security issues around that. Why is it that we're going to make this stuff available for research or other purposes, but are saying it's so difficult to manage consent? This seems crazy to me. If you're plenty smart enough to be doing big data analyses, surely you can start to do something about driving granular consent into the actual, record mechanism.
People are harder than big data.
People are harder, a lot harder. I appreciate that. So, but for me, it's what we've got. It's like it seems the. We talked a lot yesterday about sort of data protections and the law. This is more in terms of medicine. Is we've got the relationship, the trusted relationship that could be threatened. Yeah, the people who are at the high end of the scale are not at issue here. Yeah, you're quite happy. You believe, most people believe that their relationship with their doctor is confidential. If you start undermining that confidentiality. By saying, okay, well, we're just going to reach into this for arbitrary purposes, and again, it's been quite scary, I have to say, these last couple of days, seeing just how much data is being passed around. Of course, you have a different, this insurance one in the middle is probably highly contentious to my country folk. But this is something where there's a sort of continuum, I guess. The people who seem to be most concerned, the medical professionals who seem to be most concerned about confidentiality and privacy, are those people who have an ongoing, long-term care relationship with individual patients. And, as you move through, there may be sort of, I don't know, surgeons, people who are providing a particular function who may be a little less so. Then you have, people working in the public health and the, I guess, minority of doctors, certainly in our country, who work in research, who actually are quite vocal advocates of taking more data or getting access to other data. And what I worry about is that we don't have any sort of effective mechanism to pick up at this point where we transition from this scale where medical professionals who are bound by law and by professional ethics, medical ethics, Helsinki aside, not aside, Helsinki sitting there, into people who frankly don't. I mean, the only bounds are maybe a few other laws or data protection as much as it is. And that's the world that really scares me. I think it scares a lot of other patients around the world and in different healthcare systems. And I have to say again that it's come up several times during the couple of days. This notion of anonymisation as being the fix here, which though on the surface of it sounds plausible, and of course techniques of not anonymisation but pseudonymisation, de-identification, let's be accurate here, these are sensible things for us to be doing, desirable if we're going to be handling data securely. They are not sufficient in themselves for the preservation of privacy in health data. They just aren't. It doesn't work. This is what we're finding over in the UK. I guess I'm hearing a little bit in the debate over in the US. Medical data in general, because of the very nature of it, and certainly in the context of research where you want to look at all of these different variables, if you are looking, if successive healthcare episodes cannot be linked, then you can't do the interesting research, the meaningful research, but if they are linked, as Latanya showed yesterday, and we've known from many other studies, then just from publicly known episodes and the stuff that people put up themselves now on Twitter, Facebook, just on public episodes or context in the patient's life, then that can identify them, and then the linking will reveal sensitive data. So we've got this problem on the one hand, that the thing that is being used very much in the UK, I'm hearing it's being used over in the US, is, it's all okay because it's anonymous, doesn't work. So we come back to, why then, or therefore, do we not just simply ask people? If we know that the majority of them would actually be quite happy for their data to be used for research, or at the very least, for them to be asked, or to be in a pool of people to participate in being asked for particular studies. So I guess I'd leave it with my little bit, just a little bit on consent, because we have a horrible tale in the UK which may be salutary for the US as well. So we talk about the quality of consent. We talked about coerced consent. Basically, if you can't receive healthcare without giving consent, that's no consent at all. That's no choice. It just isn't. It's coercion. So consent must be informed, it must be freely given, and it must be explicit. Now, we in the UK have failed. We've lost the battle over opt-in on quite a bit of data use, which is a real shame, and we still try to push it back with every battle that we fight. But we felt we were holding on opt-out. That if something was going to be done, certainly going to be done generally to NHS patients' data, that they would be given a choice whether or not that their data was included in this. And we even have the ministers, the Secretary of State saying this publicly, saying there will be a patient opt-out. David Cameron, the Prime Minister, said every patient in the NHS will be a research patient by default unless they want to opt out. But when push comes to shove, and what we're fighting right now, literally, the last outbreak of this was last Thursday, they're not providing the opt-out. They're not giving patients the choice. They're not informing people. Yeah, they say there'll be an opt-out. Well, an opt-out in the NHS means there needs to be a read code on the system that a patient can flip.
Yeah.
Yeah?
Yeah.
That's recognisable on the system. We found, they offered 3 opt-outs. There's 1 read code, so there's missing options. But they're not even telling patients. They're proposing to put a leaflet in the practice surgery. Well, as a way of informing 50 million people in a 4 to 6 week window that they actually need to exercise a choice, even if the mechanism was in place, this is just ridiculous. Yeah? So you have to watch, I think, the slippery slope of getting salami sliced from opt-in to opt-out, notification, all of this stuff. This is fantastically important, and not just in the context of research. Anyway, I'll shut up now because it sounds like we could have a bit more time with questions.
Yeah, go ahead.
I know there's in the UK there are databases like the GPRD, the THIN. How do they relate to consent and opting in and not? How are they? I know a little about them, but not much, so I'm curious.
There are. The NHS is Byzantine in a different way,
Okay.
I guess, to the US, sort of multi-provider, multi-state situation. There used to be a thing called the spine, okay, which is about 21, 22 national centralised sort of systems, yeah, and then there is a whole ecosystem of things at sort of local, regional level, even down at practice level. So individual GPs may participate in risk stratification software provided by Capita Health, for example. That's not going to show up anywhere on the national system. Yeah, it's just their own choice as a doctor. They may pass, or they have to pass, some information, aggregate information, up to the sort of central base. This is about payment information or what have you. And now increasingly they're being asked, this new system called GPES, General Practice Extraction System, will be pulling up identifiable information from the GP systems to something called a Health and Social Care Information Centre, which sounds in theory a little bit like one of your HIEs, possibly. Health, that's the, health.
Health information exchange.
Yeah. So they're pulling up from stuff which has historically been held at the GP practice level and may have been going off to different databases for different purposes, all going into one place where they then say we're going to pseudonymise this and then pass it around.
And patients have to opt out of that.
And we want a patient opt out from that for their identifiable information, but as I say, it's not yet been properly implemented.
First, thank you both panelists. I just left 10 years at the biggest pharma company in the world and have a lot of perspective on consents. First, just a reality check on what consent tends to be in a clinical trial is a 20 to 30 page document that is meant to be readable and understandable. Now, another little thing that we look at the United States or the developed world as an example, but much of the clinical trials are happening in places where most people can't even read.
Can't read, yeah.
And I'm just thinking, about a month ago I went to Harvard for a industry-oriented, how can we share clinical trial data to help move trials along and for research. And there's this idea, and I think Lilly is doing something in this space where they're putting out patient-level anonymized to the extent it can be. And of course, we had someone else speak at the conference about how easy it was to de-anonymize, and it was DNA example. It was scary, but the same effect happened there that happened here.
Yep.
How do you explain in a consent, even in the gold standard kind of trials, formal clinical trial context, your information will be shared? How can we explain that in language fitting within the context of, say, a routine informed consent document? I mean, you spoke about informed, informed is an important word that's missing in our title here. But I'm just wondering, in reality, even if most people were, for whatever positive reasons, willing, in altruism, willing to share their data in an anonymized, or as close as we reasonably can get format, how can that be explained to potential patients or potential clinical research study subjects who want their information to move forward beyond that immediate trial.
Yeah, and that's why I wanted to get into the EHR side of things, because picture that and then time being a moving stream. So at this particular time, you may want to reveal to them that these elements are the important ones. You could opt in and opt out of anything you want to, down to the data level, but these might want to be looked at by a given researcher. And then time goes by and you say, oops, now we want to look at this. You got to figure out a way to go back and say, that's right. So how do you do that practically? Go ahead.
Okay, well, first to what you said, Bill, you were kind of getting at why are we doing this?
Mm-hmm.
And, I mean, there's only a couple answers. Expediency, we don't want to take the time.
Yep.
Consents, I've spent decades in clinical research, and I know what those things look like. I'm in West Virginia now, and the reading level in our Medicaid population is 8th grade. Someone gave me an IRB-approved document the other day that I don't think some of our college students would follow. and I brought up with my dean and said, this is not a real consent, and the IRB's out of touch. We're working to develop, for the data sets, the data-only studies, a one-page consent. It's at about an 8th grade reading level. That's what we've got to do on the data side. But what you just mentioned is actually in the omnibus rule. I worked on that some when I was in Congress, and they put some things in the omnibus rule that weren't in high tech. They weren't legislated. They just reopened some issues. And I don't know how many are aware of the prospective consent provision that's in the new rule. Basically, they're trying to address this sort of situation, which is one reason why people don't want to do consent, because we did this at Pittsburgh in an HIV study. We had actually gotten approval of sort of an open-ended consent, where we didn't have to specify every test and everything that we were going to do. Basically, when the study started, people were dying of HIV. So we had a certain leniency from NIH and others in what we did. But in the new rule, you can go in and do a clinical trial. You can biobank samples. You can do it all within one consent, and you can also do a prospective consent. Now, the guidance given by HHS is so sketchy that it worries me. But the idea being, they tried to draw a line around it, and if Deborah here, we'd be saying the same 5 things, mental health, STDs, substance abuse, the big 5 or 6 things that people talk about. HHS tried to guide investigators to say, you can do a consent that's sort of open-ended for a long-term trial. We're working one of these where I'm at. But you need to kind of wall off in such a way that patients will not be surprised at how their data is used down the road. So what you're just saying is possible now. They just sort of reopened this, it wasn't part of high-tech, and said, we want to address this concern. People they know they don't know everything they want to measure. So maybe I want to measure a biomarker in serum that wasn't in the protocol, but if it still relates to diabetes or to heart disease, I can still do that. But the problem really seems to me, after all these years, is this was absolutely unmanageable. The length of the documents, people's understanding of the documents. You do spend a lot of time recruiting and a lot of money recruiting patients. It's a pain.
And this is, I have to say, this is an issue that the informed consent documents are legal documents. They're not patient-centered, right? They're not actually designed to convey information to patients about what is possible, what may be in the future. I think the case that we heard earlier of the patient finding her information out on the web, that partially have some technical issues with that, but partially it was she read the section on the consent form that says privacy. I do research with patients. I have to do informed consent with them. I have a section on my informed consent because it's mandated by the IRB that says privacy. And it's all talking about limiting the liability of the institution that I work for in case that information gets out. It's not actually, right? It's not, it says privacy and the patients read it and they think, oh, my privacy is completely guaranteed, even though there's a sentence on the bottom that says we can't guarantee this. If there's problems, it's not our fault. Our hands are tied. So I think thinking from a human-centered, patient-centered perspective about designing communicative information that they could actually understand, where instead of it saying privacy, it says something like, we can't guarantee.
It says no privacy.
Right?
It should be honest. It would say what you won't publish. We will not publish. You say, if you sign up for this, we are going to publish your data. We will not publish your name, your address, your date of birth.
Right.
Okay? That is very simple to explain. Then you can go into, but you have to understand that other people may be able to pick you out from what we publish. Okay, I mean, in the UK we have a thing called the Ladybird books. I don't know if you have them over here. They're designed for sort of primary school age kids. Yeah, we've talked about privacy education. We talked about communicating. We need to break this down to really simple things: what we will and what we won't do as absolutes, and then the education bit. I really don't think it's that hard to say. We will not publish this.
First here, then up there.
I'm an attorney, I'm a health attorney, but on top of that, I started out in the pharmaceutical industry a couple of decades ago, moved up into medical devices, telemedicine before there was a bandwidth available, on and on and on. And it's interesting about, I think informed consent is important, but I like to bring things into the real world, because as I was speaking with some colleagues yesterday, policy people, and I'm based here in DC and do a lot of policy and regulatory stuff, make decisions based on not being on the front lines. I'm also doing some some behavioral research with physicians on the front lines in terms of meaningful use. The one thing that continually crops up is time. You expect the physician seeing the patient to educate them on consent, and informed consent is not realistic, especially when they have these requirements for meaningful use in terms of, quality measurements. They have to see increase their volume of patients due to pay cuts under the Affordable Care Act. It's just not feasible to expect a physician to have the time to educate.
If you were a patient, would you want it, though?
As a patient,
of course.
Absolutely.
Absolutely.
But that's why I think that in something like Bill had proposed, where you have a system, and you may want to elaborate on it, but envisioning where actually the patient has control of the data from, if what I'm understanding you is correct, from sort of repository that they control, as opposed to, the physician. Then the individual becomes responsible for educating themselves, for truly giving informed consent, because they're not in the physician's office giving informed consent. So there's no liability on the part of the physician, because if it becomes a physician duty, then you do have some huge legal questions.
When you have an opt-in system.
And another thing I want to say is, if you truly think that people read consents, whether they're in third grade language
or whatever,
or more complex, they don't.
No,
I
they trust.
see
They look at you and they trust you, and they sign. Go ahead, up here, real quick.
Just as an idea, I mean, it might be possible to put up, almost like a YouTube video that runs through the language, so at least people will hear it as well, and as well as have the opportunity to read it. And I can also say, from working in adult literacy in DC, the level of reading for some people can be at first grade level, so you really need that kind of global.
Yeah.
We have the same thing of if the duty is being dumped onto the clinician in UK, that's the GP. It is unreasonable, and it's happening again and again. What we previously managed to do was to force the government, as it was driving a policy of taking this data from the GP practice, to run a proper patient information program, literally, sending a letter. Now, it's not perfect. It can't be, but they actually took it out of the GP appointment, out of the surgery. We said this is utterly unreasonable. You're setting a policy, doing something over which basically the GP has very little control, the patient cares about, but it's your job to inform people. We forced a rolling program where patients had to be individually written to, provided with information, There was, broader sort of information around this as well. For a significant shift in policy about patient data, I think that was reasonable. This is what we push for each time. We're not going to get it perfect every time. What we have to have is a general awareness that there is an opt-out and a reasonable mechanism for people to be able to deploy.
As far as I know, it doesn't require a medical degree to obtain informed consent. So I think this is something that could easily be pushed off to a medical assistant or some other members of the medical staff.
I see it as, I mean, as a
anyone-
litigator, getting that, I just see it as a potential another area to worry about for the physician in terms of liability.
It's like the nice dashboard you did showing, what level of privacy you have. That's an effective way of communicating with people, and maybe the whole idea of consent needs to have some kind of a risk profile like that people can see if they're in the red, if this study's in the red area, that maybe they should ask some questions.
Okay, first over here.
What you said earlier, much earlier, Phil, about research and the funding of it and so forth. First, physicians don't do these. CRAs or nurses do the consents. And we do videos, and we do one-on-one, and we do paper, we do whatever combination the IRB or the study is designed to deal with. In our case, we're probably going to have people talk people through. But also, this is a revenue issue. This isn't a burden on physicians. If anyone here has ever done, and I've done clinical pharmacology studies, $5,000, $10,000 a patient, there's no problem
money.
with
Yeah,
this.
yeah.
Physicians are doing this for additional revenue. And we have a revenue-based research system, whether it's at Pitt where I was, or whether it's at the physician's office here in DC. So
Then you're back to the same consent you were talking about in the beginning. I thought we were talking about truly educating a patient on consenting to research.
that's not the
Because-
physician's role to educate the patient on I think, on research.
Well, I agree with that, but what I'm saying is when you say it's passed on to the assistant in the office, it goes back to our old system.
Depends what the
Or
research
repeating the
is.
system.
I think one of the reasons we're not getting consent is to some extent, people don't want the patient to know what the research is. When it was drug research, it was very clear. The physician bore the cost because they saw a revenue stream. You hired the CRA or the nurse to do this. The IRB got good approval. Now we've got all these quasi-studies that are getting into real gray areas. And the question is, how are they being funded? Would the patient consent if they knew what was being done with the data? Would the patient consent if they knew what commercial entities were involved? We've got a point now where, as of the new rule, our health system where I'm at can sell your data without consent to the public health department, which then can sell the data to someone else. Everybody can profit. The patient never even knows all their PHI now.
Yeah.
That's a meltdown situation.
Yeah.
So that's why we might have to continue this next year, actually. That's the problem, and I think everybody's voicing the frustration. We've been kind of at this end of the spectrum. Yes, another end of the spectrum is to ask for absolute consent over everything and figure out how on earth to educate about that. And there's another crowd coming in as far as, no, we don't need to do anything, or just do it once, and then after that we can do anything we want to with anything we get. I don't know. I just know that there's forces at play, and whenever I take this back, I mean, I understand the perspective of industry. I understand this perspective of the researchers, who most of the time are just, sometimes they're trying to get more money, many times they're just trying to help people. But, what really matters, I think, is if I were in these shoes, what level would I want control over? Now, the problem is that's probably variable person to person. My knowledge level is not that of another knowledge person. My wish for control is not that of another person.
Yeah.
And how do you design a system that meets the prime objective, so to speak, of putting the person in charge of what happens and at least aware, and the technical abilities to do that?
I think the word that comes to mind, because we're dealing with this in our situation with apps. People show me apps, here's a great app we can use with our population. But I've got someone who's got a bachelor's or a doctorate who doesn't even use their own health app because it's too complicated. And I said, then I've got these folks here who didn't graduate high school. We're going to use that with them. Same thing with consent. Same thing with, it was said several times, and I hear it all the time here. I know Deb likes very granular, you can check off all the boxes.
Yeah.
I was here in Washington 7 years. We're out of touch here. We're not the public. I've got to say that, and I'm in the other extreme now. the answer is stored, whether it be the consent, or whether it be the app, or whether it be what fields I want people to use. Someone should be able to, if they want to, say no research, no sharing, click the box. Someone else may say everything but my mental health. Someone may say on the consent, they're willing to sign that little short page. Other people say I have questions, they need to see the video, they have questions to answer. But we scale these things because I'm sitting here, with multiple graduate degrees, and I'm going to sit there and be a pain in the neck because I'm going to ask all the questions and I'm going to read everything.
And maybe
I'm
that's...
trying.
Yeah.
I'm trying here, right? This is exactly
Yeah.
what we're
That's what
doing.
you're talking
Yeah, it's not,
Yeah.
again, it's not exactly consent, it's preferences. Consent, I think, is a different
Same
concept, but,
scale,
yeah.
Whether it be the app you give them, whether
And maybe that's the direction, you're right, is we've designed the consent world originally anyway around risk levels, so that the riskier things needed more sophisticated consents. Maybe, that's right, the same thing is what's the risk, and we got these categories, that we think are the highest risk, but and for most people, they are pretty high risk. For others, may have other things that are high risk to them, and maybe it's...
And the data support what you just said, that people had very different preferences about what was
Yeah.
the most sensitive to them. It wasn't always what was in the NCBHS category.
And
it's the-
every time something happens, we have to make a new rule or a new law. And obviously, lawyers have to respond to every risk that came up and every lawsuit that came up, and oh my gosh, the coffee's too hot, now we got to write another thing in here. So it just grew to an unmanageable state.
This is generally the problem with increasing amounts of data, personal data, sensitive data, health data, everything. Look at it like the Facebook problem. I think Kelly's approach, if you engineer a system within which is very granular, yeah, and on each granular unit of data, whatever you want to, type of data that you want to talk about, there is the ability to switch it on or off. You create another problem for a human being, which is how do I go and switch them all? Which Facebook, basically institutionally, wants to drive you towards certain privacy defaults. Yeah. However, you can apply a better set of defaults. Yeah. You can provide little things. I mean, I've done some psychological research. My father's a research psychologist. Yeah, you could provide something that was akin to a quiz in Cosmo to try and profile people and say, well, it seems like you seem quite concerned about X, Y, and Z, and here's a set of button to set some defaults all the way across. You've still got the granular control for those who want to geek out and literally switch every single button and make every single choice available to them. Or you can have a just about good enough initial setting and then let people play with
Those
sizes.
installation and Windows, we had the little pull down thing.
This is exactly the approach that we're taking, is kind of a five option default setting,
So, yeah.
and then you can use the data after people go in and change it to then
Exactly,
modify those
exactly.
So
defaults.
keep your eye on this approach and see if it pans out over time is the right way to
But
do
what
it.
it requires-
We're going to get in a lot of trouble if we don't let people get to the lunch
Get
and
to
keynote.
lunch, right.
Thank you very much for your
No, thank you.
participation. I hope it was interesting, and I wish we had all the answers.